Our next presenter is Travis Salway Hottes. He researches the social, sexual, and mental health of sexual minorities. He is currently completing his PhD in epidemiology at the University of Toronto, where he is a Vanier Scholar. He is a board member at the CBRC and works on public health program evaluation and improvement at the BC Centre for Disease Control.
Thanks, Sean, and thanks, Olivier, for starting the session off. I am going to talk a little bit about health services. In particular, I'm going to try to make the case for secondary prevention of suicide among gay, bi, queer, and two-spirit men. And I'm going to talk about, although in previous summits I've presented a bit on my PhD research, which was really trying to outline what do we know about the epidemiology of suicide among gay and bisexual adults. And so I'm now really motivated and really inspired by the work of the three gentlemen at the table here and some other people who aren't with us to really put our heads together to figure out what does a broad intersectoral suicide prevention strategy look like. So I'm going to start just by talking to you about what are the levels of prevention. And this is public health jargon, so I apologize. But I think it's helpful jargon if we're interested in planning a suicide prevention strategy for gay, bi, queer, and two-spirit men, which I think is coming. Maybe next year at the summit we'll introduce it. So what is primary prevention is probably what most of us think about when we hear the word prevention. This is actually preventing disease before it starts, preventing the onset of illness. But for most diseases, of course, primary prevention is not 100% effective. So that's why we have secondary and tertiary prevention. These are safety nets, if you will, to help people if we don't actually stop the onset of an illness. So secondary prevention refers to public health efforts to detect an illness or a disease early on, so that we can actually take care of folks earlier in the course of illness. And tertiary prevention then refers to all the ways to reduce the impact once someone's affected by an illness. So I've given you some examples here for what this looks like in the context of HIV. So primary prevention includes things like condoms or provision of injection drug equipment or pre-exposure prophylaxis. Secondary prevention refers to testing for HIV and hopefully testing early, so using approaches like the acute HIV test. And tertiary prevention, of course, refers to treatment. So what do these levels of prevention look like for suicide? Well, first, I think it's helpful to think about suicide as a process and not as an event. And this is increasingly what suicide researchers around the world are doing. They're kind of reconceptualizing how do they talk about suicide for the very purpose of intervening earlier. So this is a model from Rory O'Connor, who's from the University of Glasgow. We're fortunate to have Lisa McDade here from Glasgow. She's a colleague of Rory's. And Rory O'Connor's contribution was to say, for too long, we've talked and thought about suicide as a byproduct of mental illness, and this is really slowing us down. We're not thinking about it as a dynamic process. If we think about it as something that changes over time, then there's more opportunities and more targets for prevention. So this is his model. It's one of many that sort of conceptualizes how does suicide actually happen. It's called the Integrated Motivational Volitional Model, and I really like it because it happens to map perfectly to primary, secondary, and tertiary prevention. So you can see on the left panel here, he talks about a pre-motivational phase, and this includes things like the life events and the factors that might predispose some people to suicide. Unfortunately, some people in some social groups are more likely to be affected by these pre-motivational factors than others. And a lot of the stories that Olivier was highlighting were actually showing how early on in life, some people actually, their chances of kind of getting into this whole process are a little bit greater. But you'll notice there's a long center section that he calls the motivational phase. And this is really when, if we think about suicide as a dynamic process, this is when thoughts of suicide start to happen. And it's much more complex than I'm going to give it credit today. There's lots of interactions, right? Because it's not so simple as I've had a challenging life and I wake up one day and I'm thinking about suicide. But in fact, there's lots of different social and internal processes that are interacting to lead people closer and closer to the volitional stage, which is when someone may actually attempt. And that's separate in his model because thankfully most people who are thinking about suicide don't go on to attempt. So what about in a queer context? What do then the primary, secondary, and tertiary prevention levels look like? Well, primary prevention refers to the kinds of programs and activities that promote mental wellness early on in life. So those of you who were at the summit 2 years ago will remember that Elizabeth Saywick came to talk to us about research that she had done actually surveying all of the high schools in the province of BC every 3 years and noticing that the high schools that implemented queer straight or gay straight alliances in their schools actually had a subsequent reduction in thoughts of suicide. So this is kind of early on primary prevention. And these examples, Philip asked earlier about interventions, these examples of true primary prevention are unfortunately rare, at least in the queer context. A secondary prevention is something like the Safe Talk program that Sean talked about. So how do we actually get people, everyone in the community, at lots of different organizations and settings, thinking about and identifying folks who are struggling and who in particular are thinking of suicide? So remember I said secondary prevention is kind of identifying this process early, and then tertiary prevention refers to all of the services that support folks who are actively and persistently suicidal. So an example that comes to mind might be psychiatric treatment for someone who's recently attempted suicide. So today I'm going to focus on the motivational phase. So I'm going to talk specifically about secondary prevention. My assumption is that for most people, this motivational phase takes time. And that means we have time to intervene. And if we have a broad enough strategy, if we're clever enough in how we link together our different organizations, there probably are multiple opportunities to intervene at this stage. And why secondary prevention? Why don't we just start with primary prevention? Well, ideally we'll have all three, and ideally we'll have robust primary prevention, but until primary prevention is 100% effective, we need programs that are in place to support folks who are moving along in that pathway. So right now, the case distribution, if you will, for queer suicide probably looks a little bit more like this, where probably there are a lot of folks who are thinking about suicide. Olivia shared the statistic earlier, which means we need to do more right now. The primary prevention programs like the one that Elizabeth Saywick talked about are fantastic for future generations of LGBTQ people, but they're not doing a lot to directly support the current living cohort of queer people. So these are the questions that I've been thinking about a lot lately. I'm going to try to answer a few of them, but mostly just throw them out for discussion. So the broad umbrella here, in fact, the topic for our whole session is how do we effectively identify and support gay, bi, queer, and two-spirit men who are thinking about suicide. I'm going to try to convince you why I think we need a broad intersectoral approach, although probably many of you already agree. And then I'm going to ask how the data that we've pulled together on gay, bi, queer, and two-spirit men who are thinking about suicide tells us where else we should be intervening, and then throw out some questions for next steps. So 3 reasons why we need a broad approach. The first is that clinical approaches are not working, and this isn't specific to queer people. In fact, I was just at a suicide research conference a couple of months ago, and the general consensus is that despite decades of work in clinical settings to try to predict who's going to go on and attempt suicide, it turns out to be a very, very difficult event to predict. And this is in part because suicide is a rare event, and so there's statistical problems in prediction. But also, if you think about the context of a busy outpatient clinic, there may not always be time to really understand what is or what isn't a sign or symptom of suicide or distress. You might falsely identify someone who you think is struggling, but they're not, or you might miss some cases. The second reason is that suicide is a dynamic process. So someone might be seriously contemplating suicide one day, but the next day they might not. So it just depends on actually when you're actually crossing their path. I've done volunteer work at the Crisis Center. My observation is that's really the premise of a lot of the work that is done there, is that if we can get folks who are in that moment of crisis, if they're really distressed, if we can get them through that day, the next day might look a little bit different. So what does this have to do with breadth? Well, if I only see my family doctor 1 time a year or 4 times a year, she may miss seeing me on the day that I'm actually in one of these states of crisis. So it really does take a village, a broad village, to be identifying folks in crisis. And finally, as we all know, the barriers to accessing help when it comes to suicide and mental health generally are many. This is kind of my concept of how the barriers stack up. I put access at the bottom because we could eliminate all of the stigma in the world around mental health services service access, but if the mental health services are not there, then that's useless. And access here means not only is there a clinic available, are there counselors ready to talk to me, are they close by, what about the time, but also the cost, which is a major barrier in Canada, and I suspect just about everywhere. And then once the access is there, are they culturally appropriate? Everyone, including gay, bi, queer, and two-spirit men, are very sensitive to whether a particular provider or clinic are a good match for them. Do they understand what I'm going through? Is this a good place for me to go? And that's why we have services like the Health Initiative for Men, which Aaron will talk about in a moment. And then stigma. So we know, in our case, related both to sexuality and to mental health, people receive messages that they're not welcome or that their social status is somehow different based on stigma, and that will keep them from coming in. And then finally, awareness, which is kind of like the cherry on top for me. I think awareness of services is really important, but I'd argue it's probably the easiest thing to tackle out of the four. So it turns out these four barriers are exactly the same barriers that we were dealing with around secondary prevention of HIV not that long ago in Vancouver. And in response, we've started to effectively deal with each of these barriers. And as a result, HIV testing rates among gay men in Vancouver have never been higher. So here, you can get tested at the STI clinic, you can get tested at the Health Initiative for Men, you can go to the hospital. In fact, it's now a matter of routine practice in the hospital to test everyone for HIV. You can get tested at your family doctor, you can get tested online, you can get tested in the bathhouse. So my question is, can we do the same for suicide? Can we have a broad approach to suicide prevention, secondary suicide prevention, that is mindful of these barriers and that is as creative as we've been with HIV prevention? So I'm going to share with you just a few of my own observations around where I think we can go when it comes to secondary suicide prevention. I've spent the last year doing interviews with gay men who've attempted suicide as adults, and although the purpose of the interviews was not to ask them about health services access, it couldn't help but come up. As part of their stories, they talked about there are many different ways in which they crossed paths with healthcare providers, and two things struck me. The first one, I don't know if you'll be able to read these, so I'll just kind of summarize them for you. The first one was the number of places in which they felt judged by healthcare providers and in the healthcare system, and the cumulative sensitivity they had to it. Now, I don't think that this is necessarily because there's lots of bad healthcare providers out there, but I think people quickly become sensitive when that judgment is perceived on the basis of their social characteristics, something that they've been conditioned to learn about. So the first quote is someone talking about actually his third suicide attempt happened when he was alone and fed up and wasn't really getting along with his healthcare providers. He was fighting with his doctor, he was fighting with his caseworker, just really trying to get away from them. And was also having some interactions with his caseworker where his caseworker was really reacting really badly around issues of gender identity and gender presentation. A second participant talked to me about how, really he's had really fortunate experiences in Vancouver for the most part, has a really great family doctor, and yet this one negative healthcare interaction sticks in his mind. It was the second time he attempted suicide. He was admitted to the hospital, and the psychiatrist he saw in their very first meeting asked him, so how long have you had this food addiction? And the participant's floored. He's in a moment of crisis. He's just attempted suicide, and all of a sudden this other health issue completely unrelated comes up. So people become really sensitive to the system, which tells me it's probably not enough just to have admissions at the hospital or just to have a family doctor or a caseworker. The other thing that came out, which is really consistent with what Olivia has been talking about in their Photo Voice project, was the number of spontaneous and creative solutions these men came up with, kind of workarounds, if you will. So one talked about volunteer work he did with a gay organization, and he talked about how actually now, if he needs help, if he's feeling very alone and feeling distressed, a couple of people working at this organization are the only people he would actually reach out to. Another participant said, I guess essentially some people don't like to talk, but that's how suicide prevention is kind of premised. He said, that's supposed to solve all our problems, but everyone has a different way of learning. And so his suggestion was to try arts-based approaches, try music, try art, try ways to keep their mind active, which is exactly what the Still Here Photo Voice project is doing. So these were qualitative impressions I was starting to get that a single solution, just training up family doctors or just improving access to counselors, is probably not going to be enough. What about the quantitative picture? I have 5 minutes left? Okay. So in Sex Now 2015, the survey that wrapped up last year, we found, as Olivier alluded, about 1 in 5 respondents had thought about suicide in the last 12 months. And of these, we know that 38% actually talked to a healthcare provider about it, whether that was a family doctor, a counselor, a psychologist. So that leaves, now we don't know what their level of suicide ideation was. Was it just for a day? Was it relevant to something in particular that was going on in their life and they found another solution? We don't know. But for the moment, let's just assume that the remaining 62%, 924 men who answered the survey, had been thinking about suicide in the last year and didn't talk to anyone in the healthcare system about it. So where else did they intersect with people in the system? Well, first of all, among these 924 men who were thinking about suicide but didn't talk to a healthcare provider, 62% actually have a family doctor. I don't know, it's glass half full, glass half empty. That's quite a bit lower than access to family doctors in the general population and lower than the Sex Now survey average, but okay, there's some access there, but maybe they're seeing that family doctor once a year. 27% were going to a walk-in clinic. 40% actually saw a mental health care provider, a counselor, or a psychologist, or a social worker. Of course, we don't know if they were thinking of suicide at the time that they had that discussion, but they at least had that point of contact. 55% had an STI test. So they're doing just as well with STI testing, maybe a little bit less STI testing than the average. 55% expressed interest in PrEP, although this was at a time when PrEP wasn't approved in Canada. And 18% had volunteered with a gay organization. Okay, here's the most important statistic. 98% of them had accessed at least one of these points of service. This is why we need a broad intersectoral approach. There is no one single setting where we're going to cross paths with men who are isolated and are struggling with suicide. It has to be broad and it has to be intersectoral. So where do we go from here? Well, these are some questions that I don't have the answers to, but these smart people do and you smart people do. The first is, what barriers can we address locally now? And I would argue we know the answer to this question, and I think we're doing it. And Aaron's going to talk next about the program at HIM, which is specifically mindful of these barriers and looking at ways to get around it. And by the way, is also, you know, I was really inspired by John Pachankis' talk this morning, really thinking about, you know, today we're talking about suicide, but in fact, underlying this is a lot of other mental health and psychosocial struggles. So if we can come up with approaches that are transdiagnostic, that are kind of looking at how do we address suicide while addressing other health issues, that's great. And I think that's the beauty of the program at HIM. Then what about the level of mental health literacy among gay, bi, queer, and two-spirit men in BC? This is something Olivier's talked about for a long time. In other words, how good are we as a community at talking about suicide and depression? And I would argue, although we don't yet have the data to back it up, that probably our mental health literacy is not quite at the same level as it is for HIV. So assuming that we have a ways to go, how do we scale programs to build mental health literacy? And I think the Queer Safe Talk program that Sean and his colleagues at the Crisis Center have been doing is an excellent start. And lastly, this is where my head is at right now. What are those unique, untapped, creative points of contact for gay, bi, queer, and two-spirit men struggling with depression or suicide? You saw in the previous slide that over half of them have accessed STI testing. We know, I know from the interviews I've done, that a lot of folks don't feel totally easy talking to their family doctor or regular healthcare provider about their sexuality. So we know that a lot of folks actually split their services, and they go to their family doctor for some things, and they go to the STI clinic for other things. So maybe the STI clinic is one of these sites. In fact, it already is. We know anecdotally that a lot of folks come to the STI clinic to get their HIV test, but they're bringing with them a lot of other health concerns related to relationships and depression and substance use and anxiety. So how do we support the good work that's happening, that the nurses are already doing at these STI clinics? So we've started to do a survey that's coming out this week at a few of the STI clinics in Vancouver, where we're actually asking clients, what's your experience been like talking to STI providers about mental health, and what can we do to support them so that they are then a point of intervention? So I'll stop there, and do you have time for a question?
We have time for question.
In talking about stigma, and talking about barriers, I'm wondering, I just have this sense that, while mental health issues are stigmatized, like suicide is even further stigmatized. So we have some deeply ingrained sort of attitudes, cultural, societal attitudes around those that attempt or commit suicide. So I'm wondering, like, is there much research around social attitudes that may act as barriers to actually recognizing and addressing the issues of suicide? And then I wonder what that would look like in the gay community.
So I just want to make sure I understand, Philip. You're asking, is there research that would point to how people are responding to social cues about suicide?
No. I guess what I'm getting at is I feel like people don't want to talk about suicide,
right.
but also that we have attitudes around those that may attempt suicide, may consider suicide, and that might actually be a barrier, to actually addressing suicide as sort of a subset of mental health sort of response.
Yeah, I mean, anecdotally, I would agree with you. I can't pull any research out of my pocket right now, but just based on my experience at the Crisis Center, I would say that's true. I think people do feel that stigma, and then, I think there's fewer places for them to actually talk about it.
Because I guess I'm just wondering about there's barriers that we talk about, there's interventions that we talk about, sort of with specific services, and then the practitioners in those services. But I guess I see more perhaps structural and social barriers that actually will make it more challenging to even get to the sort of the direct service aspect of things, and it's sort of I think about anal sex and the taboos around anal sex, right? And how that has been such a barrier in HIV prevention to even doing HIV prevention and doing gay men's health. So we talk about suicide. If we can't actually, if there's these larger barriers that are that are both personal but structural as well, how do we get to, and how do we understand those barriers so we can sort of work through them?
No, I think that's a great idea for where to go from here. I mean, I think, I don't know if a campaign is the right direction, but I think, still here, if you haven't seen it yet, it's hard to go there and not at least have some conversation about it. So I think there are little examples of this that we could look at scaling that start conversations. Just story sharing is a really big piece. So I think I'm starting to see more stories come out about so this is where I think actually we do need something particular to gay men. We're starting to see more and more stories come out about mental health and specifically about suicide and people who've had experiences with suicide. But what I've heard, at least in some of the interviews, is that it feels like this added pressure, and this is maybe part of what John Pachankis was getting at this morning with that kind of best little boy in the world hypothesis, this added pressure around how we have to behave as gay men, don't show these certain faults or weaknesses that make it even harder to then acknowledge when there's been a struggle. And I think you're right, that's at least it's systemic. And I don't know how to get through that other than story sharing, having people come out and talk about their experiences. And, maybe that's something for next year at the summit to get more people with lived experience talking and kind of sharing what's happened. But I agree with you. It's a big thing to tackle. Yeah.
Thank you.
How are we on time?
I think we'll move to Aaron and
Great.
then have time for open discussion.
Good.
If that's all right with you.
Yep.
Thank you very much, Travis.